Mm-hmm.
Okay, let's just do this.
Is it recording?
Okie dokie. So, hi, good evening, everybody. Welcome to tonight's training. Ronnie is a volunteer that works for Tick for Lyme, and she is also a trained psychiatrist. And she has very kindly offered to do a session tonight for us on psychiatric diagnoses, which I know that I will find very interesting, and I hope that everybody else benefits from this. So, Ronnie, I would like you to introduce yourself, and you are very welcome. If everybody could mute themselves, I'd be very grateful, and then we can start.
Yeah, hi, great to meet you guys. So I am a psychiatrist, practice in the US. I'm a clinical assistant professor at George Washington University. Finished my training in 2015, have an interest in global health, a lot of ties to Israel. In fact, I'm planning to come over and volunteer next week at Beit Yaakov in the hospital there. But in the meantime, happy to do some training, help out. My understanding is that you guys are all therapists, right? Licensed therapists.
Yeah.
Okay. So, I mean, I'm sure that a lot of this was going to be a review, but I'm not going to sit there and like read the DSM criteria for diagnosis because that's something we can all look up. What my goal is to basically go through a few nuances that I find a lot of people maybe struggle with as clinicians, psychiatrists, NPs, whatnot, where sometimes we have a hard time differentiating certain diagnoses and certain symptoms, like what do they mean? So I'm going to go through a few things like that. And then I want to open up to like case discussion since we have a small group, because I think that would be the most helpful. And maybe we could talk about some cases together, obviously like anonymous, don't tell the patient information, but I always find that's the most helpful thing. So I can go ahead and do my slides. It won't take too long, and then we can go ahead and have a discussion if everyone is good with that.
Okay,
Yeah.
that's fine. Thank you very much.
Wonderful. Could you allow me to, let me share the screen?
With pleasure. There we go.
Okay. I don't, okay, I'm going to try to share my screen, okay? Can you guys see?
There we go. Yeah.
Okay. Okay, wonderful. So let me go ahead and start the slideshow. All right. So let's just talk about a few nuances that I think, like I said, can be a little bit tricky. Let's start with anxiety disorder. So I'm not going to go into too much detail in the differential diagnosis here because honestly, at least for medication management, a lot of times, all the different anxiety disorders we mostly treat in a similar way. Most people do well with SSRIs, Buspar, and they're all kind of rooted in this fight or flight response, the parasympathetic versus the sympathetic nervous system. And when that fight or flight or sympathetic nervous system takes over too much, and that tripwire is triggered too much, it can lead to an anxiety disorder. This could be something someone has a genetic predisposition for, or it could be due to traumatizing events like, combat and assault, things like that. One thing I really love to recommend for people with anxiety disorders, if they've had any kind of trauma, is a book called The Body Keeps the Score. So please check it out if you haven't. It's really helpful and it goes into the neuroscience and really helps patients understand their parasympathetic and sympathetic nervous system responses. I really recommend breath work for anxiety disorders. I think that is one thing that really, really helps most anxiety disorders and has basically no side effects, and it can be very powerful. And just another thing to think about with anxiety disorders, they can really affect physiology, like the whole body. So it can trigger hypertension, cardiac arrhythmias, all kinds of physical effects because when you have these catecholamines, epinephrine, norepinephrine, and then over the long term cortisol circulating in the body, it definitely has an effect. I think more so even than some other psychiatric conditions. So it's really important that patients are aware of that mind-body connection when they have anxiety disorders. One thing that I just want to point out, obviously this is a med management thing, but it's really good to avoid long-term benzodiazepine use. That's like your Xanax, your Klonopin, Ativan. Benzodiazepines can really help with anxiety in the short term, but they can be very problematic in the long term. They can lead to addictions, confusions. In the elderly, they can cause a lot of falls, memory problems. And it's always like people always need more and more of it to control their anxiety. So we really try and recommend to stay away from it if at all possible. People with OCD often require higher doses of SSRI medications than other anxiety disorders, just something to think about. So you have a client with OCD and they're saying their medicine's not working. Sometimes we even go above the highest recommended dose for OCD patients. So it's just something to think about. Like if their medicine's not working, tell them to talk to their doctor because it's quite common that OCD in particular needs those high doses. And sometimes even like an additional medicine beyond an SSRI. So these are just some examples of anxiety disorders: generalized anxiety, panic disorder, social anxiety. And like I said, we commonly use SSRIs, buspirone, and then for as needed, sometimes propranolol to block that fight or flight response if the person doesn't have asthma or hypertension issues. And then hydroxyzine also for anxiety, although it can definitely lead to some drowsiness in people. Something you'll probably run into as therapists in Israel, given the amount of trauma recently, is PTSD, some people call it either or. And diagnostically, 1 month or more of following a trauma, of re-experiencing avoidance, negative alterations in cognition, mood, and then alterations in arousal, that fight or flight response. Note that it's often comorbid with substance use because a lot of patients attempt to self-medicate their PTSD. So a lot of people will turn to alcohol use, can have alcohol use disorder, marijuana dependence. So just something to think about for sure, even nicotine dependence. So bear in mind, it can definitely lead to comorbid substance use. One thing that I think a lot of clinicians do struggle with is differentiating bipolar 1 and bipolar 2. And I've seen this a lot with people I work with. One of the main differences is the severity of symptoms. So if a person has mania that requires hospitalization, it's bipolar 1. So if they end up in the hospital while they're manic, just clearly that is bipolar 1. It may also involve hallucinations and delusions. And more often than not, if they've had hallucinations and delusions, it's not bipolar 2, it's most likely bipolar 1. And it's really important because, I mean, for therapy purposes, probably the treatment will be similar, but for medication purposes, the medications that we use to treat bipolar 1 and bipolar 2 are quite different. So in bipolar 1, we have to specifically make sure they take medicine to prevent manic episodes because they can be very disruptive and dangerous. That could be lithium Depakote. And then in bipolar 2, the mood stabilizers are more mild, so to speak. So it might be using lamotrigine. Second generation antipsychotics might be used for both conditions, but we might use different ones for bipolar 1 and bipolar 2, depending on how severe the hallucinations are. So some second generation antipsychotics block the dopamine receptors more strongly. And so we might use those in bipolar 1 if they have severe psychotic symptoms. But in bipolar 2, we might use milder medications that are still second generation antipsychotics, but have a kind of a more mood stabilizing effect. And another thing to differentiate, right, since these both have psychotic symptoms, bipolar 1 versus schizophrenia. So the main difference is psychosis only happens during mood episodes in bipolar 1, usually during manic episodes. For instance, common scenarios: a patient travels, their jet lag causes them to mess up their clock, they stop sleeping, and then start having delusions of grandeur about being a prophet. Whereas patients with schizophrenia, their psychotic symptoms occur in the absence of any mood symptoms or mood stable. They both commonly begin in late teens, early 20s, but women tend to develop these psychotic illnesses a little bit later in their mid-20s, and also have a second peak later in life as their estrogen wanes in menopause. So estrogen is thought to be protective against psychotic illnesses. That's why you see that second peak with women. And then you have kind of a combination of bipolar 1 and schizophrenia, not to confuse everyone. But this disorder, schizoaffective disorder, it involves a major mood episode. So either a regular one unipolar depression or a manic episode. And it also a 2-week period of psychotic symptoms when a mood episode is not present. So if you look back here with bipolar, the mood episodes have the psychotic illness symptoms, right? But here you have a separate mood episode, may or may not have psychosis, but then you also have psychosis when there's no mood issues. So I know it's a little bit confusing, but essentially, if the symptoms of psychosis only occur with mood, think bipolar 1. If they occur with a mood episode, only bipolar 1. If no mood episode, either schizophrenia or schizoaffective. And then you have to look and see, like, was there a 2-week period when there was not a mood episode? Okay, and then differentiate schizophrenia and schizoaffective. And just to clarify, mood symptoms included elevated mood, depressed mood, possibly suicidal ideation, apathy. Psychotic symptoms include hallucinations, typically auditory, but not always. Delusions can be paranoid, delusions of grandeur, etc. Major depressive disorder can, not to make it more confusing, can also have psychotic features. If they have psychotic features, typically it's mood congruent. So let's say like the devil telling you that you're a terrible person and you deserve to die, okay, rather than something more positive, like I'm a prophet or something like that. They tend to have like a negative character to them. They usually require hospitalization because it can be very, very negative and kind of self-depreciating kind of psychotic hallucinations and delusions. Command auditory hallucinations to commit suicide are a particularly high-risk symptom in this disorder. Also want to point out there's treatment-resistant depression, which by standard definition, there's no like clear definition, by standard definition is 2 or more failed medication attempts. It's still treatable, but often requires a more unique approach to treatment, maybe multiple medication combinations and or other modalities like TMS, ECT, psychedelic medicine like ketamine, and et cetera. Alcohol dependence, often see it with comorbid mood symptoms and anxiety disorders, especially PTSD. Mild to moderate, we often use medications like naltrexone, acamprosate, Vivitrol to control cravings. And these medicines can be very helpful. In severe alcohol use disorder, we often need to hospitalize the patient to help them detox safely because you can't stop severe alcohol use cold turkey. You can have life-threatening withdrawal symptoms, including seizures, delirium tremens, things like that. And after they detox, then maintenance therapy with things like naltrexone, acamprosate, Vivitrol, and then treating comorbid mood and anxiety disorders. Just a quick mention of depression and pregnancy. Most SSRIs are thought to be safe in pregnancy. There's a tiny risk of fetal lung problems if they're taken in the third trimester, but it's very, very small. And with the exception of Paxil, most SSRIs are thought to be safe. And untreated depression and anxiety also has risks in pregnancy. So as clinicians, the standard is usually to continue the medication that the patient is taking. And also in breastfeeding, in particular, Zoloft or sertraline is very well studied. And with postpartum, most patients can take these medications. In addition to SSRIs, I often restart Wellbutrin if they stopped it while they were pregnant, and other medications beyond SSRIs while they're breastfeeding because it's safer. So a minute to talk about postpartum psychosis. That is a very, very dangerous psychiatric emergency. Patients often need to be hospitalized and unfortunately, separated from the baby. It's typically a mood episode with psychotic features. So similar to like a bipolar 1 episode and or a major depressive episode with psychotic features. Lack of sleep could be a risk factor. So it's really crucial to recognize this and differentiate this from postpartum depression, like without psychotic features. This is a very, very high risk, dangerous situation and needs immediate attention. And so that's pretty much it. I just wanted to open up now to discussion and talk about some cases together, answer any questions you might have. Yes.
Hi, I know we don't know each other. I was a professor of psychiatry at UCSF for many years and taught psychiatric differential diagnosis for 15 years. It's really complex. I have to commend you for this incredible task you've taken on to give this incredibly brief overview on incredibly complex vortex diagnoses. Yeah. Bravo, really, bravo.
Thank you.
I'm a specialist in bipolar, and it's an incredibly difficult differential diagnosis to make. And I just wanted to add, and excuse me if I didn't hear when you said this, that it's one of the most difficult diagnoses to differentiate because it looks like so many different things, like you're saying, like schizophrenia, it has many different aspects. Mm-hmm. And I think something as helpline people, what we should look out for is kind of like, what are we looking at? Not that we're all expert in knowing how to do differential diagnosis, but because the highest risk of suicide is with people with bipolar type 2 particularly, because it's so unstable. So I just, I'm thinking about I'm just thinking aloud, like, how do we, in terms of our group, how do we let our volunteers know about some things to look out for? Yeah. I think it's wonderful what you're doing. This is great. And by the way, we're in the same area because I'm in Washington, D.C. So
okay, yeah. Well, yes. I think also one thing to point out is mania is a high risk time for suicide. And people might go from like very, very high, thinking they're a prophet and all of that, to committing suicide during a manic episode. It happens. So just because they're elevated does not mean they're not high risk. And just because someone doesn't overtly say I'm suicidal doesn't mean they're not high risk.
Right, so. Because they could be talking to you and they're so impulsive that they could get off the phone with you and want to just kill it because they're just thinking so quickly.
Exactly.
And they're not things through. Absolutely. It's one of the scariest diagnosis and it has the highest risk of suicide of any of the psychiatric diagnoses. Yeah, it's a lot.
Yeah, that's why getting the diagnosis is really important, because also traditional antidepressants won't really help with bipolar usually. They can actually trigger a manic episode.
Right, it can make it worse, and I think it's been decided. I think that I don't know what the American Psychiatric Association says, or the AMA, is that it's contraindicated in the treatment of bipolar.
Yes, SSRIs. So you could take SSRIs for a comorbid anxiety disorder if you have bipolar, but you should be on something to prevent mania. So you should also be on a medication, mood stabilizing medication in addition to the SSRI.
Right. I'd like to contact you outside of this to talk us through this.
Of course.
That
Yeah.
would be great. Okay, great. Thank you.
It feels,
Yeah. Do you got, yeah, sorry, go ahead, Susan.
I was going to say that it feels like this is really very complex, and a lot of these terms and names we've obviously all heard of. And some of our clients will tell us openly that they suffer with bipolar or they suffer with this, and they're on medication.
Yeah.
However, it's the ones that aren't on medication that feel they don't need to be on medication that in our therapy that will call us and say, oh, I'm fine. But you can see and hear in their voices that actually they're saying such bizarre things to you that are beyond comprehension, and you understand from the way they're presenting there is something seriously going on here. So
Yeah.
something I suggested
It's tough.
Yeah, I had one particular client who I'd been working with for almost 2 years. Very, very poor history of mental health. Stemmed from being sexually abused as a young child. At least we believe that was where the root was. Parents not believing him and him trying to prove that he was right, but parents cast him on one side, ignored him, and he went through life, and then he came out that he was gay. So he had a heck of a lot of stuff going on. And you could hear the way that he was talking about, they're watching me. I can see them watching me. I know they've got my phone. I can hear them on the line. You know, I can tell when they're tapping into my line, and just saying the most bizarre things. And eventually I said,
Okay.
you need to see a psychiatrist. You know, I was direct, that you need to see a psychiatrist. What you're
So you bring up a really good point, Susan. So sorry to interrupt, but I just want to make this point that PTSD, severe PTSD, can also trigger psychotic symptoms.
Yes.
Especially like complex PTSD. If people get very severely activated, we do see hallucinations and delusions in severe PTSD, particularly when with like borderline personality disorder. If they're very dysregulated, psychotic symptoms can happen.
How do we recognize what a real psychotic incident is? Because I'm hearing things. I'm not, at this particular client would never use Zoom. He would only do the telephone. So I wasn't able to see him visually. In the end, it was obvious that something had gone wrong because he was screaming around Tel Aviv center, running in the middle of the road and doing really bizarre things. And eventually he did get sectioned. But it's very hard when you're not trained in a psychiatric way to know how to balance that session with a client, to meet them on the level which doesn't really exist in my eyes in that moment.
Yeah, it's very tough. If they have psychotic symptoms, most people don't have insight into their psychosis. Some people do, you know, it happens in PTSD more so than like schizophrenia and bipolar. I would say a lot of people with PTSD related psychosis will realize that they're seeing and hearing things that aren't there. But again, encouraging them to get, like you said, psychiatric help, super important. Psychosis is not something you want to play around with. Most people with psychosis, if it's not treated, can be high risk, like you said, running into traffic and whatnot. You know, it can be very dangerous. If you can get family members involved, if he has support family and they allow it, I highly recommend talking to family members as well.
And that sometimes can be challenging because the family themselves won't recognize what their child is actually experiencing. They go into that denial stage that my child is suffering in this way. They think they just need to give them a good talking to, which we know, as my limited smidgen of information, is not correct. Can you explain to me also the difference between PTSD and complex PTSD, please?
Yeah, so complex PTSD, I think it's like a more recent kind of term. And from my understanding is it's recurrent trauma, right? So like PTSD can happen from one terrible event, you know, like let's say like something on October 7th.
Yeah.
But complex PTSD is a series of traumas, often when the brain is still developing, like someone who's growing up in an abusive home, for instance. So it affects the person differently. And Suzanne, you might have something to add on that as well.
Ask you, it's a big issue for me to try to understand in the psychiatric community. My understanding is this like the new way of saying borderline personality disorder? Because that's been
possible. Yeah. Like I think, yeah, like, you know, the way I see borderline personality disorder is like it has elements of PTS, but there are also parts of borderline that are unique to borderline, right? So because it happens like so early in the person's development, it affects their attachment issue, you know. So yeah, I think it could be conceptualized that way, but some people with complex PTSD, I think, don't have borderline. I think borderline is complex PTSD plus more things.
So it's kind of like earlier traumas, like earlier based traumas where the person hasn't developed necessarily borderline personality characteristics, but it's just like a succession of traumas that have accumulated over time versus like PTSD, like someone going through a war trauma.
Yeah. And they respond like a certain way to things like throughout their life because of the initial trauma. But I don't think everyone with complex PTSD has borderline. I think borderline has complex PTSD plus some other things like related to attachment issues and such.
No, because it's true. I've only just started in the last 3 or 4 months on intakes hearing people mention complex PTSD, and I'm thinking, you know, I don't ask them about it because I don't want to go too deep with them.
Yeah.
I'm kind of wondering what the difference is, and that makes a lot of sense to me, that complex means lots of trauma, whereas PTSD is one significant trauma, which is something that perhaps we're now dealing with our own soldiers.
Yeah, or like a rape or something like that. Like you know, but also, you know, complex PTSD, I think a lot of people use that term when they had ongoing trauma in their development in particular. Not everyone. I think some people like in abusive relationships also use complex PTSD, but like I think for the most part, from what I've seen, it's used in relation to people who had trauma in their development.
If anybody else got any questions, because I have another one and I don't want to hog Ronnie. Okay, is schizophrenia hereditary?
Yes, it can be, but the risk of passing it on is quite low.
Okay.
So I believe I have to look back. I don't know off the top of my head what the risks are, but it is, I think, like 50% chance of an identical twin having it. I think it's around 50%. And I can't remember what it is for like parent to child, but I think it's like around 10%. So it's not that high.
Okay.
Yeah, it's not that high. I have to double check, but it's not like that high. So there are definitely environmental factors. And if people are worried about passing it on, I mean, it's a real concern, but no, it's definitely not like something where you're guaranteed to pass it on. It's not like you get the gene and that's it. Like Huntington's, it's like 50%, you know, a disease like Huntington's disease, 50% of your children are at risk for this illness. But it's much lower for bipolar, much lower for schizophrenia. And remember, these things are treatable. I have people with schizophrenia patients who lead a totally normal life on their medications or professionals. So many people do very, very well. So yeah.
Okay, it's very interesting. I find this fascinating. Thank you. I really do. Really appreciate it.
Yeah, sure.
Has anybody got any questions they would like to ask Ronnie while we have her? Because this is really very interesting. There's silence. So when we are working with clients, especially at the moment when we are getting, like one of my clients has been in Gaza for quite a few weeks, and he was in a really bad place when he spoke to me on Motzei Shabbat. He was starting to say like he was experiencing tics and twitches, and certain things were really uncontrollable crying and feeling extremely scared and vulnerable, like he needed to run away. To me, that sounds like there is trauma starting to creep in. Is that the start of PTSD?
It might be, it might not be. It could be just acute stress disorder, which is kind of, it is a diagnosis, acute stress disorder, prior to 1 month, a lot of people have these reactions and they do get better. So, just something to think about. It could be a sign that, he needs a break if it's at all possible for him to rotate out, and have a break. So, because, people can't always perform at their best if they're having these symptoms.
Mm-hmm. Mm-hmm.
Part of what I find helpful in working with PTSD is that, at least I've worked mostly with war journalists, but is that if they're in a situation where you say, you normalize the experience for them, even though it's abnormal, you say, this is very common to experience this. This uncontrollable crying. There are subsets of people who do feel this way, so they don't feel so sick. They don't feel so labeled.
Yeah.
There's so much individual variation with that, but I find that very, very helpful to get somebody to feel less. It actually can reduce the anxiety.
Yeah, and it's an injury, like it's like any other, like if they hurt their arm or their leg, it's just an injury on the brain. So like, I tried to normalize it with like veterans and things like that.
I like that. What you said, it's like an injury on but that's a great metaphor. Thank you.
Yeah.
That's wonderful. Yeah, it's really good.
Yeah, and to destigmatize it as well, because some people feel like, oh, why am I weak? But no, like what you're experiencing is normal. It's just an injury. Some people get it, some people don't.
And this will pass over time. You kind of give the suggestion. These are things that you can potentially expect so that they don't feel so frightened.
Yeah.
Suppose when you say it's an injury like anything else, does that normalize some of the other kind of mental health things that you've talked about? Or is that
well PTSD in particular is very much triggered by the environment, like something in the environment that made someone feel threatened. So what I'm saying is, like, if they're at war and they had a traumatic experience, PTS is an injury, just like as if they were harmed, like by if someone shot them in the leg or something like that. Because a lot of people will have like this stigma, like, oh, I'm leaving my soldiers, I'm weak, why can't I just get over it and move on? And it's a physiological response. It's an injury, and it should be treated like any other injury. But some of the other illnesses and conditions I talked about, they can definitely be worsened or triggered by stress. Stress pretty much makes all of them worse, everything. But in particular, I'm like talking about like veterans in this case, since you brought up the young person in Gaza.
Yeah, stress is something I think we see in the majority of our clients. Anxiety is something we see in the majority of our clients. The way that they perceive that anxiety, how we try to help them manage that anxiety if they're choosing not to be on medication. There's a lot of work. I think this is kind of, for most of us, it's kind of, I used this term before, but I think it might not be but in England, it's a recognized term. It's like bread and butter. In other words, it's the normal kind of patter that comes into us in therapy. Anxiety, depression, they're the ones that really come in. And I think we see a lot more of it, and people are not able to recognize what's going on for themselves, hence the reason they're coming to us to help them be able to see that. It can be very challenging as a therapist to be able to work with clients because they can be very, sometimes disrespectful, because they're not
Yeah.
capable of being respectful. And
Mm.
therefore allowing that to come into the room as well, that balance, that dynamic of where you're speaking to somebody who is really quite curt and rude, but actually allowing it because we know they may not be able to help this kind of behavior. And it is a hard thing to manage in a room and with a client.
Mm.
I notice it a lot with some of the intakes that I do. And sometimes those intakes don't make it through to our therapists, because I feel, in my limited judgment, that they actually need the care of a psychiatrist before they're able to come into therapy to kind of normalize the way that they're thinking and seeing things.
Yeah.
Is that right or wrong?
Yeah, no, I think what you're saying makes sense. There's probably a great deal of like transference going on,
Mm.
uh, given the current state of affairs.
Mm-hmm.
Um, so it makes sense that they might be like reacting this way, feeling like this is one area where they can control things.
Mm-hmm.
Yeah.
So it's important really to have that safety network of a psychiatrist working alongside us so we can balance everything.
Yeah, definitely. Yeah, I mean, just knowing when it's time to like be like, hey, a lot of the patients that come to me end up saying, hey, my therapist felt I should see a psychiatrist.
Mm.
Like, I say like maybe even half. So I think you guys serve a very, very important function to kind of nudge the patient to, make that decision.
Mm.
You know, I find challenging is that because, depending on the culture that you're working with, is that psychiatry is so stigmatized.
Yeah.
So
Yeah.
I want to see a psychiatrist. So what I wind up doing sometimes, depending on the culture I'm working with, is to say, you know what, these a lot of these things are medically based, or they're medically exacerbated. So
Yeah.
what would be helpful is if you could talk to a physician, a psychiatrist is a physician.
Mhm.
Doesn't mean you're crazy or whatever the words are they use, but I think it would be useful to get some really sound medical advice about ways to look at this. And you don't have to take the advice of the psychiatrist, but the more information you're armed with, the more likely you are to be more confident in being able to manage your symptoms. And we can work together with your, psychiatrist. I'm like, I've been doing this so long that I think, I used to use labels like,
Yeah.
sure. And now it's like people freak out. I don't even use the word depression any longer with people. I
Yeah.
say,
Yeah, I get it.
can mean a lot. I said, well, I described the symptoms. Well, I don't have bipolar. I've been a bipolar specialist for you. I don't have bipolar. I said, okay, that's okay.
Yeah.
You don't have bipolar. That's fine. I don't care about the words. What I care about, the diagnosis. I said, what I care about is symptoms and what
Yep.
you're experiencing. So your mood shift, or you get really agitated really easily sometimes. Well, I don't have bipolar. I said, that's fine. But what we do know is that your mood shifts when this happens. And when that happens, then you start thinking this way, and then you start going down the rabbit hole. So what can we do with those symptoms so that you don't have to feel so bad any longer? I like stay away from the diagnoses. I wish I had known this 40 years ago, because how many people have I lost in my treatment because they just didn't want the labels of depression or bipolar or ADHD or whatever. So your challenge is enormous because I'm the psychiatrist, and how scary that is for so many people.
Yeah, no, definitely. And I'm originally from Ukraine, so I totally hear what you're saying about culture. And like the culture that I come from, it's very, very much like, what do you mean you're gonna go see a psychiatrist? Like it's no, people don't do that. And the other issue was, psychiatry was used to control people who were dissidents, right? So there was that aspect of it too. So people who were against the government were thrown into psychiatric facilities. And then you have like other cultures, like for instance, like the Beta Israel in Israel, from Ethiopia, where if you have like an illness, a psychotic illness, it could be like something that is looked at in a very different way. than in the Western perspective, right? So they might have a very different approach to healing something like that. So I think having a cultural context to these conditions, depending on who you guys are working with, is so important, and how to talk to the patient, you know, and how to have that conversation.
Make a very interesting presentation, because like I've lived in France a long time and working with many different cultures, like the Balinese, for example, or certain African cultures where they talk about the spirits. So you have to talk about the spirits, or you talk about the different gods in Balinese Hinduism, animist culture, and you have to talk about the different gods. Like I'm working with an Indian man now who is very much a believer in all the different gods, and he has very severe OCD with psychosis. And it's like, you can't mention those words, and the family won't hear it. They just won't hear it. You have to talk about the different gods and bring them into the picture. So it's it's fascinating.
It's very fascinating. And I think Israel is like a perfect microcosm for transcultural psychiatry, because it is so diverse.
Or it's like the States, right? We get everybody from everywhere. So
exactly.
People who make Aliyah, and they come, right, we've established Israel.
You notice in Israel particularly that there are certain cultures that never even pick up a phone for therapy. You know, there's certain communities that do things like that. We just get on with it. I mean, I suppose I could say this safely 2 years ago, but when I was working with a client in the West Bank who was suffering with very, very deep depression, and he said to me, I'm not even allowed to go to the chemist. I've managed to get a prescription for medication. He says, but I can't go and get the prescription filled, because I would be, my community, if it got out, I would be shunned. And I'm like sat there. I mean, this guy lived in a very old house, and they were the wealthy ones in his community because they had a well in their garden. So they didn't have to go and get water from somebody else's well. They were able to collect their own water. This is like 3 years ago, right, in the West Bank. And it's like a completely different perspective on life. You know, I couldn't believe that I was in 2022, 2021 when I was working with this client. Such unbelievable.
And it could also, like in certain communities, they might be afraid it could like affect the marriage prospects of siblings, things like that. So it's like it's so important to know the cultural context.
It's fascinating.
The person, the family,
I find this whole area just really fascinating. For me, it's something that I could really delve into, because it is fascinating. And you're right, Israel's a melting pot of cultures. I think the last count we had over 100 countries that have brought Olim into Israel.
That's amazing. And that's also why it's so important to have like therapists, psychiatrists of different backgrounds, so like the patients will feel comfortable opening up more a lot of times. So
absolutely. Wow. Has anybody got any more questions?
This has been fascinating.
Absolutely.
I think there's so much more to say. To talk. But I think would be really interesting, is, Susan, as an idea, is to try to get together different mental health professionals from different countries, from different backgrounds, to have like a forum where we have a discussion. We might present something. How would you work with this as a Ukrainian therapist, as a Russian therapist, as an Israeli, as as a French, as somebody from the Cameroon, or Japanese. I taught, what is it, in San Francisco, everybody comes from the Pacific Ocean over the ocean. They're like Asians. That was the hugest challenge. I don't know what you get at GW, but it's an enormous challenge, because we don't show emotion. We don't talk about illness. We learn to buckle up, and you say it in private, because God forbid my family should reject me. I mean, like what you were talking about, Susan, like the Haredis also.
Yeah. I mean,
I have family who are Haredi in Israel. They don't even want to talk to me, because they think what I'm doing, that's not the way you approach it. That I'm a lost soul because I'm not religious enough. I'm not in that community. I mean, it gets really out there. So I
Yeah,
think
there are Haredi therapists, like, there are,
Yeah, we have.
so
it depends on you're talking like really on the edge there, but I think it
yeah,
would really be interesting, Susan, if I mean, to think about it as like a conference of sorts or something, it'd be really interesting.
That would be very interesting. We have to go and find some people, but we could definitely be interesting. But I
yeah,
think that would be really fascinating to do. Really
yeah,
fascinating. Good idea there, Suzanne. Very good idea. And it's
yeah.
true because, we deal with, we do get people into Tikva by the mental health program who've run away from the Haredi communities, and they're needing some support because they've actually become irreligious. They no longer want to be
Mm,
connected. And there's
that's
that
very hard. Yeah,
identity crisis that they now have,
yeah,
and
yeah. They lost their support, the support network. It's very,
Right.
very hard.
completely oystered. And there are organizations that actually specialize in working with these people that
Yeah,
have come away from Haredi communities. That actually also could be a very interesting subject to have
yeah, yeah.
That'd be
training.
great.
There is an organization that actually do that here in Israel, that they bring these kids into an organization, and they support them in all ways of integration into non-religious worlds. So let's have a look at that. I love it when this happens. I just brainstorming undeliberately, completely not deliberately to do. It's fascinating. But that's the whole thing about Kipulim. We work with all people of all diversities. So, we've had a really kind of eclectic client base over the years, because of that. And it's fascinating, it's really fascinating, and things that you hear. But when you were talking before about labeling, and I know we've just got a few minutes left about labeling, in my training as a therapist, I was always taught you never listen to labels. You do
Yeah.
not ever class a client with a label, and you never internalize the label that they have, because that's not for you to say. That is what the client brings in. And I think that's very freeing for people in a therapy session when you allow that.
Absolutely. I think also certain diagnoses, like you mentioned, borderline personality disorder, they do carry a lot of stigma. And I tend to like kind of avoid diagnosing that, honestly, because there is more stigma. Although some patients, they find it very freeing to get that diagnosis because they're like, oh, now I finally understand why I am the way I am.
Mm.
So I think to reiterate, that, hey, like you're a person, you're not just like a borderline or whatnot. You're a person with a condition that people get better from and live with. And um, it's something you can live with and move forward with your life. Also, especially like with first breaks with young people, it could be very, very challenging for the family and for the young person. Like, one minute they're in college studying, then boom, they're in the psych ward with psychosis, because around that time is when these illnesses typically present. So it's so important to give hope that many people live a full, healthy, normal life, and reiterate the importance of staying connected to your treatment team, your psychiatrist, because every time they come off of their medicines, disrupts their life, creates chaos, potentially makes it harder to treat in some cases if they keep coming off their meds. So getting them early and kind of not labeling, but giving them hope that, hey, like you can manage this. Don't be in denial, but giving them hope. It's like a fine line. It's really important.
There's also
You sorry.
It's okay. I was just going to say there's also that connection for a lot of people that have tried some medication and had horrendous reactions to it, and it puts them off even going back to the psychiatrist, because all they're going to do is give me medication that makes me feel woozy or dizzy, and I can sleep for days and I don't feel any better. So that's their negative. All of a sudden they've got that negative
Yeah.
attitude, and that's very
Yeah.
difficult.
Yeah. Yeah. Not everyone will need medication. A lot of people with mild to moderate anxiety and depression, they don't. But an illness like schizophrenia, typically, if ever done bipolar 1, when they start to feel better, they come off their meds, it creates a disaster in their lives and their loved ones' lives. So really important to reiterate that they need to be on medicine.
Mm, mm.
I like what you said about, I use this word, you reminded me, condition. I never say disorder. They come in and they say, I have depressive disorder or have anxiety disorder or OCD disorder. I said, I don't know what that is. A disorder, it's just an ordering of your neurochemistry.
Yeah.
And you have a condition. You have a condition that manifests itself this way because when you use the word disorder, you're suggesting, or you label someone, you're suggesting to them also what their behavior should be. So they're thinking, oh, maybe this is how I should be also. They try to fit into that depending on how anxious they are. Oh, it's just such a fascinating concept about stigmatization and labels, utilization of symptoms. You can actually utilize people's negative symptoms, destructive symptoms as a positive to help them pull out of it. It's really fascinating.
And the thing is, like, a lot of these conditions, to use that term again, have a positive side. That's one thing we often forget. So like bipolar disorder makes people very creative, high energy. A lot of times really successful people have bipolar disorder. A lot of CEOs and whatnot. Makes you think outside the box. ADHD, definitely a lot of very, very successful creative people have ADHD. Because they're all over the place, they make new connections to new ideas. So very successful, like startup people often have ADHD. Creative types tend to have mood disorders, artists, poets, etc. And honestly, like, part of it is like people don't want to stay on their meds because they want to feel those mood swings, and fuels their art. So that is one challenge to think about with some patients who are artists. So yeah, there are positives to these things, like people who are kind of anxious make good surgeons and whatnot, they're kind of more, so yeah, it's not like these things are just negative, so.
And it's interesting you say, because the IDF now have recognized that people with on the autistic spectrum, ADHD, they've actually now got a unit, IDF, specifically for people on that spectrum, because they realize they have so many gifts in areas that they can give. They may not be able to do combat, but intelligence, all these particular services. And Israel's pioneering this. It's one of the things that Israel is pioneering, and it's proven to be successful. So
that's fascinating.
Yeah.
So as opposed to it being a detriment, like let's say the U.S. military, where they don't screen out the people that just can't do combat or just can't be in certain situations, they're actually utilizing those symptoms to their benefit. That's fascinating.
Yeah. Because they want to do something, they want to be involved, but they may not be suitable for combat, but they may have many gifts that they can do because of what Ronnie's just said, that they can actually have a lot to offer to the IDF in other ways. So why should they be precluded?
Yeah,
they're utilizing it into a really positive thing. Okay, so Ronnie, I found this session like it's flown by as if it's been
right.
Yeah.
Well, I'm glad we got to do it. And if you guys have other topics down the road, I'm happy to go more into depth about things like postpartum or pregnancy and things like that. So let me know. I'm happy to do it again and go into depth about something. Or we can do like case consults. So yeah, let me know.
Postpartum is very interesting because we do get women with postpartum depression, and you don't always know what to say to them. We had one this week, very, very depressed lady, but we've got her a therapist who specializes in that, so we're able to help her.
Good.
But it's understanding, for me, I like to understand a lot about this so it can help them to help me and me to help them. So yeah, thank you.
Oh, great. Yeah. Please feel free to reach out to me. Susan, feel free to share my contact if people have questions concerns, I'm happy to talk.
Thank you
So
so
I just wanted to say, even though I'm retired a very long time and not seeing anyone at the moment, I learned a lot of fascinating, very helpful information. So
Thank you,
I
Barbara.
just want you to know how much I appreciate that.
Thank you so much. Thank you. Thank you all.
Thank you. Okay, thank you.
Thanks for all you guys do. Yeah. Hopefully see you around.
Okay. Take care, everybody.
Thanks.
If
Bye.
you're in America and you're kind
Thanks.
of on holiday,
Bye-bye
enjoy
now.
your
Thank you.
holidays. Okay.
Bye.
Bye. Thank you.